My name is Ahmed Miftah. I'm presenting the surgical site infection with my colleague Madeleine Al-Abbar. The surgical infection is the major problem in surgical practice. In 1992, the US Center for Disease Control revised its definition of the wound infection, creating the definition of the surgical site infection to preventing confusion between the infection of surgical incision and the infection of the traumatic wounds. Account for 15 to 25% of all surgical infections, increasing cost of healthcare. The definition. The infection of the wound can be defined in wound infection can be defined as the invasion of the organism to the tissue, leading to what? Leading to the systemic and local presentation like redness, hotness, pus formation. The most causative agents for the surgical site infection is Staph aureus, then the gram-negative bacteria, Escherichia coli. Those are the most common cause. What are the risk factors for the surgical site infections? We have more than one. Two types, local and general risk factors. General risk factors like poor general conditions, malnutrition, obesity, patient has systemic diseases, diabetes mellitus, jaundice, immunosuppression patient even. While the local risk factors like patient, poor hygiene, poor technicians, poor surgical techniques, foreign body materials, poor perfusion, leading to shock. There is many types for the surgical site infection, many classifications. The first one, depending on the depth of the wound infection, it will be. It could be a superficial incision surgical site infection that involving the skin and subcutaneous tissue, while the deep one is involved the fascia and the muscles. The organs or space surgical site infections involve the internal organs. The further classification depends on the etiology. It could be primary or secondary or the other definition like endogenous, exogenous cause. Endogenous cause such as the following perforating peptic ulcer, the patient himself, poor hygiene or something. But the secondary or exogenous cause acquired from the doctors from the instrument that use it, nosocomial. Depends on the time, another classification, depends on the time. There is an early, intermediate, late. Early, infection presenting within 30 days. This is the most common, I read it. The intermediate occurs between the 1 to 3 months, while the late presenting after 3 months of after surgery. The severity depends. There is a minor severity, major severity. The SSI, other classification, depends on the type of the operation. There is many types, like clean operation, which is elective procedure with risk for SSI 1% to 3%. The other one called the clean contaminated, which is mechanical, using the mechanical drain, non-inflamed, risk for surgical site infection 5 to 80% to 8%. The other one is contaminated, called the contaminated operation, which is account 20 to 25% risk for surgical site infection. The last one called it dirty operation, which is 30 to 40% for surgical site infection. What are the complications of the SSI or surgical site infection? There's many complications like fistula, sinuses, necrosis or gangrene of the affected parts, suppressing wound healing, immunosuppression and superinfection, systemic inflammatory response syndrome, and the multi-organ system. Failure of the multi-organ system, the most serious complication. How to prevent the SSI? To prevent it pre-operative by pre-operative measurements, post-operative measurements, operation theater procedures, blood sugar, also antibiotic and prophylaxis. A pre-operative, staff should be always washing their hands, avoiding shaving before the surgery, if it's possible, antiseptic skin, should be cerebralized preparation. Attention to the theater techniques could be cerebralized. Avoiding hypothermia or hypoxia by ensuring supplemental oxygen recovery. Operation theater, ensuring sterile caps, masks, gowns, gloves used. Skin cleaning, providing iodine, using drips, dry instrument, sterilized, avoiding plastic drips, absolute homeostasis, appropriate sutures material, avoiding dead space. Severely contaminated, leave upon. Principles of the antibiotics therapy. Antibiotics do not replace a surgical drainage of infection. Only spreading the infection or signs of the systemic infection justify the use of the antibiotics. Antibiotic therapy approach. We're using two types of the antibiotic: narrow-spectrum antibiotic, broad-spectrum antibiotic. Narrow-spectrum antibiotic for known the causative agent for this, after the cultural sensitivity, while the broad-spectrum antibiotic we're using for if the bacteria unknown or when the suspected several bacteria involved with the operation acting in the surgery may be responsible for infection. A new antibiotic should be used with caution whenever possible. Sensitivities should first to be obtained. A prophylaxis choice for antibiotic. Empirical cover against expected pathogens with the local hospital guidelines. Single shot IV administration at the induction of the anesthesia. Repeat only the prosthetic surgery, long operations, or if there is excessive blood loss. Continue as there unexpected contamination. Patients with a heart valvular disease and prosthesis should be protected from bacteremia caused by dental work, urethral instrumentation, and visceral surgery. Those are regimes operation. It depends on the type of the surgery and the organism involved. We're using specific regimes. For example, the vascular surgery, the most common cause it could be Staphylococcus epidermidis, which we use 3 doses of fluoxetine or with gentamicin, vancomycin. We can change the vancomycin with the rifampicin as the MRSA as risk. Orthopedic Staphylococcus epidermidis or aureus, 1 to 3 doses of broad-spectrum antibiotic, cephalosporin or gentamicin. Esophagastric enterobacteria or enterococci, 1 to 3 doses of the second generation cephalosporin, metronidazole, and the severe contamination. Biliary procedures, biliary surgery, it could be enterococci or enterobacterium, 1 dose of the second generation cephalosporin, so on. The treatment of the surgical site infection. Treatment depends on the type of the SSI, as what I said. The surgical debridement of the wound, suture and remove with the free drainage, fluid, culture sensitivity, suitable antibiotic, signs of the healing, secondary suture. Those my references. Thank you.
Good afternoon. My name is Madeleine Labbar, and today I will present the new research of the implementation strategies to reduce surgical site infections. So the abstract background, as we know, the surgical site infections brought in the high morbidities and mortalities, although evidence-based clinical interventions can reduce surgical site infections. They are not realized, delivered in the practice, and the data are limited on the best approach to improve the adherence. The objective to summarize the implementation strategies aimed at improving adherence to evidence-based interventions that reduce SSIs. Designs, systemics review. We should know what's the systemics review. Systemics review, it's the very complication research. Meta-analysis is the statistical methods to summarize all studies and research. Methods, search at PubMed and Cochrane Library, WHO's, and the Africa-wide for the studies published between January 1990s and December 2015. The effective practice and organized care criteria were used to identify the acceptable quality studies designs. We used the structures formed to extract the data and the implementation strategies and grouped them into the implementations models, called 4E's. It's the engaged, educate, execute, and evaluate. The result in total is 125 studies meet our inclusion criteria, but the 8 studies meet the EBOC criteria, which limit abilities to identify the best practice, and the most studies was multi-phased strategies to improve the adherence with the evidence-based interventions. Engagement strategies included multidisciplinary work to strong leadership involvement, and education strategies included the various approaches to introduce the evidence-based practice to clinicians and the patients. Execution strategies standardize the interventions into the simple takes to facilitate the uptake. Evaluations assess the adherence with evidence-based interventions and the patient outcome, providing the feedback to perform to providers. Conclusions, multi-facet implementation strategies represent the most approach to facilitating the adoptions of the evidence-based practice, and believe this is summarize the implementation strategies, complements of existing clinical guidelines, and may accelerate effort to reduce SSIs. The introductions, it's the global problem associated with the increased morbidities, hospital length stays, and the hospital readmissions and costs. So the most frequent healthcare-associated infections, complaining the evidence show that several effective interventions prevent the SSIs. So, and the both WHO and US Centers of the Disease Control and Prevention recently issued guidelines outlining the most appropriate prevention measurements. So several approaches have been described to improve the adherence of the evidence-based interventions. So use the model used to translate the evidence into the practice known as 4A's: engage, educate, execute, and evaluate. This model has been initiated to prevent thromboembolic events and increase the early mobility to practice among the hospital's patients. So, and the administrations of the clinical stakeholder and has technique to adaptives work to foster to translations of the evidence into the bedside practice. The methods, the data source of the search strategies use the PubMed Cochrane libraries and use the Africa-wide informations for articles published for the 1st January 1990 through the December 31st of 2015. Use the comprehensive database specific to combinations of the term including medical subjects, headings related to the SSI's prevention measurements. Inclusions and exclusion criteria, eligible studies describe the strategies to increase the adherence of the evidence-based interventions known to reduce the SSIs, so include the experimental observational studies and randomized controlled trials, controlled before and after studies, interrupted time series studies, and the quality improvement initiative. All the surgical patients populations of the settings, inpatients and outpatients, and the patients of the all age group were included. Study selections on the data extractions article were selected the several phases. First 6 reviewers independently screen and title and generate at least potentially abstracted of the conclusions. The second, 4 authors independently reviewed the abstract, identifies the articles from the full text reviewer and read the article for eligibilities. Analysis of the implementation strategies summarize the implementation strategies according to the one of the 4 framework categories. So these categories were not always mutually exclusive. Reviewer decided on the best fit through the group consensus. The results identify 30,798 records in initiate research and 2 articles from the reference lists on the identify studies. After removing duplicated 9,823 unique titles reminders, of which 7,342 were excluded because inclusion criteria were not met. of the remaining 2,481 records, 2,106 were excluded because studies objective was not mere or on abstract was not provided. So the remaining 375 studies underwent full text reviews. Of these, 255 were excluded, leaving the 120 studies in our final analysis. An additional 5 studies were identified from another search of the systemics review, providing 125 studies in the final analysis. The analysis includes 124 coherent studies and 1 randomized control trials. Demographic characteristics, it's the overall 105 studies, 84% were conducted in the high-income countries and 60% in the low-middle income countries. Also, 40 studies, 12% evaluate the pediatric populations, and the 88% evaluate an adult, mixed adult and pediatric, or undefined populations. Quantified the studies by the surgical specialties, 21 cardiothoracic and 22 orthopedics, 13 obstetric and gynecologies, and 23 gastrointestinals, and 3 neurosurgeries, and 2 plastic surgery, 28 multiple specialties, and 13 undefined specialties. So the adherence to the surgical site infections prevention measurements, the most common measurement was appropriate use of the surgical antibiotic prophylaxis, which reported in the 86 of the 125 studies, 68%, and 14 of 20, 70% studies, conducting in the low-middle income countries. The other common prevention measurement with surgical site preparations, 31% hair removal technique, 25% normothermia, 20% glycemic control, and 18% wound care, and 70s preoperative bathings, and 16s operative room disciplinary traffics, and 14% instrument sterilizations. 30% was for sterilizations, and the hand hygiene was 11%. Preoperative cleaning was 40%, and the gloving technique 8%. These strategies, engagement strategies, among all the studies, it's 63% describe the effort to engage the fourth-line staff and to implementation strategies, largely by forming the multidisciplinary teams. So this diagram, it shows the infections control and hospital epidemiologies. The identifications record the identified through the database screening 30,798, and additional record identified through the other source was 2. Recorded after duplicated remove 9,823, screening record by 2,481, recorded excluded 7,342. So the eligibilities for the text article assessed for 375, the full text article excluded for the not addressing effect interventions of 255. These included studies, quantitative synthesis is 125. We have 5 additional studies obtained from the searching by biographies, so studies that of EBICO criteria was 8. Education strategies in the total 65, 54% used some form to staff educations at the implementation strategies. Traditional teaching methods included large group workshops, ground rounds, and the other methods included peer educations, role playings, briefings and debriefing sessions, and live simulations. This table shows the infectious preventions and control measurements for all the studies. The surgical antimicrobial prophylaxis of all the studies was 84. In the low-middle income country was 14. Skin prepper techniques in all the studies was 37, and in the low-middle income countries was 4. Hair removal techniques was 29. In the low-middle incomes was 3. Temperatures control, it's 24, and then the low-middle incomes was 1. Glucose control, 22, and 1 in the low-middle incomes countries. Wound care, sterile dressings, 20 in all studies. and 3 in the low-middle income studies. So operations room, disciplinary and traffic cleanings, 17 from the old studies and 1 from the low-middle income countries. Instrument sterilizations was 50 from the older studies and the 4 from the low-middle income countries. Preoperative chlorhexadines from 17 of the old studies and 0 of low-middle income countries. So gloving technique is the very important of the old studies was 10. So in the low-middle income countries was 0s. Staphylococcus aureus screening and decolonizations was 12 of the old studies and the 0 in the low-middle income countries. So the method of the wound closures was 5 and 0 in the low-middle income countries. Bowel preparations practice of 7 in the old studies and 2 in the low-middle incomes. Goal-directed intravenous fluids 4 in the old studies and 0 in the low-middle income countries. So isolation protocol contact protections 3 of the old studies and 1 of the low-middle income countries. Or ventilation control was 3 of the old studies and 0 of the low-middle income countries. The conclusion in this systemic review defined the 125 studies that describe the implementation strategies to increase the adoptions of the evidence SSI prevention measurements and categories of strategies according to the 4E's framework. So to both encourage the multidisciplinary teamwork and obtain leadership's buy-in to increase the staff and the patient's awareness and knowledge about the SSIs and the prevention practice, to standardize the simplified clinical process and to create a verification procedures and to provide times feedback to stakeholders to support improvement efforts. So we have the new studies and new research regarding to the SSIs in the Benghazi Libyans was conducting in the Injala hospitals by Dr. Athman al-Tajouris. It's the under processing and will be reached the public mid in the next month, inshallah. The background of this is the third most commonly reported noxomial infections, and the objective to define the prevalence of the SSI and risk factor implicating organism involved, the material and the method of these studies conducting in the Department of the Surgery, El Jala Teaching Hospital, Benghazi, Libya. We use its descriptive case series studies and the data of 204 cases who underwent surgery in 2018. The result in the studies is analysis of the clinical data of 204 patients out of 40.7% were infected post-surgeries. The most common bacterial cause of these surgical site infections was Streptococcus aureus, and the 4 statistically significant risk factors. These patients prolonged operative times, extended hospital stay, and urgency of surgeries, and along with anemia. Conclusion, in the present studies, infection rate was higher than that in developed countries. Some risk factor was significant associated with an increased rate of surgical site infections. Staph aureus was the most common organism isolated. The other comorbidities did not directly affect the rate of SSIs in these studies. Recommendations: correcting the anemia before the surgery and decrease the operations period might be reduced the SSIs. So nurse and technicians training in the OTs and post-operative work to improve the healthcare's qualities. Early nutrition support should be begun to improve the patients in the hospitalizations. Monitoring systems and antibiotic policies should be developed, and the qualities of the control practice should be turned into the routine, and medical doctrine should be done to regularly. Keyword: El Jala Hospital, surgical site infections, emergency, Staphylococcus aureus, prolonged hospital stays. These are the references, and these are the quiz to you. It's why SSIs. So what's the conclusion you get it from these journal clubs? And thank you for your attention.